Good afternoon, everybody. And at the outset, I thank all of you who have come despite their busy schedule on Saturday morning, and you're still here listening and learning all the excellent topics which we thought will be of great help to all of you. So, continuing the journey of academics, I'll be talking on optimizing heart failure management as per the guideline-directed medical therapy, with a special focus on ARNI only. The most important thing for any heart failure patient is that we should make sure that the patient's lifespan is increased. And we know that in India, mortality rate in heart failure with reduced ejection fraction, definitely it increases with time. And if you see here in this, the in-hospital mortality, which is almost 10%, and gradually when it goes from in-hospital to 30 days to 90 to 1 year to 2 year and 3 year, it has gone up from 10% to almost 40%. So this is really very distressing. Despite all the advances, we still have not been able to reduce this significant mortality. But definitely the newer treatments which are available, which if we give them judiciously and we give them in right doses, then we should be able to make a difference to patient. So lack of GDMT, it's a known fact. If you don't give the medication in proper dose, definitely it causes higher mortality. And you can see here, the yellow curve is the GDMT, and the gray one is suboptimal therapy. And you can see clearly the mortality, cumulative mortality is higher if you are giving optimal therapy. And this is an Indian data. I'm not quoting any Western data. So the most essential way to combat heart failure is we have to look at how are we going to give our guideline-directed therapies. Although it's a major cause of mortality, the effective medical therapy do exist, and the ACCC and the Heart Failure Society have given guidelines how are we going to use these therapies so that we can improve the patient outcome. Now let us look at one patient, which is a 58-year-old female who is diagnosed 4 years back with NIHA class 2 heart failure. Now currently this patient is on ACE inhibitor, beta blocker, diuretic and MRA. Now, what are the symptoms? The patient says, I am able to do my daily routine work. Occasionally, I take break and then again I resume work. To me, it looks absolutely fine. The patient is absolutely fine. She doesn't have any other issues. She is absolutely stable. There's no complications. She doesn't have orthopnea, PND, anything. So I think she's properly managed. But is it so? The patients, when we look at the investigation, the echo shows EF 35%. Renal parameters, blood pressure, potassium, all are good. The NT-proBNP is also relatively good, 125. So all this suggests that patient is well managed. And I hope you all also must be agreeing that yes, this patient is pretty well managed. But do we have any scope of improvement in this patient? Because if we follow GDMT, we are going to reduce mortality. But do you think the patient is optimally managed? What will be your next step? Initiating and continuing the GDMT really keeps these real-world patients live longer. And now if you do not give GDMT, you can see the mortality keeps on going as per the duration. So patient not on GDMT, they have a 29% higher risk of mortality compared to patient who are on GDMT. I think there is nothing great which I have spoken, or nothing great the trials are showing. What are the guideline recommendations? The ACC, AHA, they say that hospitalization for heart failure with reduced ejection fraction is a critical opportunity to continue, initiate and further optimize the GDM, because that is the time when patient is really worried, because he has been hospitalized, he was in ICU, and he is really worried that if I don't take my medications properly, then probably I may come back again. So that is the time when patients are most amenable to all the treatments we suggest them, and that is the time when we should initiate all the GDMTs which have been found to be of benefit in terms of improving mortality. So continuation of these oral GDMT during hospitalization has been shown in registries to lower the risk of post-discharge death and readmission compared with the discontinuation. And what is the most important and the latest drug which have been found to improve mortality? They are the ARNIs, SGLT2 inhibitors. And right now, because I have said I will be focusing more on ARNI, so I will go a little bit more into the details. So ACC guidelines, they recommend sacubitril valsartan as the first line therapy for all heart failure with reduced EF patient. So it is first line therapy for all HFrEF patients. Anybody who has a LV dysfunction, EF is around 40% or low, and this patient must be on ARNI unless and otherwise there is some contraindication. In chronic symptomatic HFrEF patient who are on class 2 or class 3 who tolerate an ACE inhibitor or ARB, the guidelines have started recommending that you should replace this ACE inhibitor with a ARNI. ARNI is recommended as de novo treatment in patients who are naive, and if they had heart failure, and if they did not have any ARNI before, you can start them. Or if they are already on ACE inhibitor ARB, you can change and upgrade them into ARNI again. So this is the status of ARNI right now in the current GDMTs. Even ESC guideline also says the same thing. It's again considered as a first line therapy. ARNI should be the first line instead of ACE inhibitor in all HFrEF patients. So if you see that patient, the patient was having all the drugs, but the patient was all on ACE inhibitor ARB. So we need to make sure that this patient ACE inhibitor is uptitrated, and we should start initiating the patient on ARNI rather than continuing with the ACE inhibitor. Initiation of ARNI in recently hospitalized stable patient with HFrEF, including those who are on ACE inhibitor ARB naive, is also safe and may be considered.